Hi, I'm Dr. Sam Mann, and this is Beyond Conventional Medical Thinking. And in this episode, we're going to talk about a very common, very troubling disorder called chronic fatigue syndrome. Chronic fatigue syndrome affects about 3 million people in this country, and it affects them severely, also known as myalgic encephalomyelitis. It's defined as persistent or relapsing fatigue lasting at least 6 months, not substantially alleviated by rest, and it results in substantial reduction in levels of activity for many. The three main symptoms are fatigue, post-exertional malaise, feeling exhausted after a modicum of physical activity, and unrefreshing sleep. Other symptoms, some have difficulty thinking or concentrating. Some have what's called orthostatic intolerance. They're dizzy when they stand up. It's unclear why, although I wonder if the amount of time spent resting results in less ability to maintain the blood pressure standing up. It's a matter of deconditioning. Symptoms have been going on for at least 6 months. They may wax and wane, but they recur and last a long time. And this is a serious disorder. About 25% with it are either bedridden or homebound most or all the time. Patients do not have fever or enlarged lymph nodes or laboratory abnormalities. There are obviously many other causes of chronic fatigue, and physicians have to do tests to look for other causes, anemia, other things, and they have to look for those. But here, we don't find a reason for it. This was first described centuries ago, and yet the cause remains unknown. There are many theories, but to this date, nobody really knows. Mechanisms, theories include genetic predisposition, immune response to lingering viral infections, COVID, mononucleosis, and others. And in a proportion of patients, it is a post-viral illness, but in many others, it is not. Also, possibly unexplained inflammatory process, but again, there's no explanation. And then there are many other guests. There are no diagnostic tests that can say, yes, this is chronic fatigue syndrome or not, but we need testing to exclude other conditions. Treatment. There's no cure. There are many suggested treatments. Studies suggest that the effects are modest. For pain, one can take anti-inflammatories such as Aleve, Tylenol, low-dose antidepressants. One can take antidepressant for depression, but its efficacy is not clear. Deficits in attention, nobody knows what to do. So lightheadedness, fludrocortisone or midodrine, which can raise blood pressure. Beta blocker if the heart rate is fast. A long list of medications have been tried, but no clear or significant benefit has been shown for them. Behavioral therapies, cognitive behavioral therapy, graded exercise therapy with care not to overdo it because that can worsen the fatigue. There's some modest benefit, but it's not great. So to sum up, we don't know the cause, we don't have diagnostic tests, and we don't have a clearly effective treatment. It's been disappointing. So we need new thoughts. So one question we have to ask, is it a mind-body disorder? Studies show that about 2/3 of patients with chronic fatigue syndrome have depression or anxiety, but that most often is likely a result of having this debilitating condition. It's not the cause of it, but a result of it. Importantly, studies that have looked at the prevalence of anxiety and depression in people who don't have chronic fatigue syndrome those who develop chronic fatigue syndrome are no more likely to have depression or anxiety before the onset than anybody else. So that also does not fit as a cause. Does psychotherapy help? It may help in coping. It's not a cure and has not had a major impact in the treatment of chronic fatigue syndrome. So where do we go from there? What does my experience suggest? I don't see that many patients with chronic fatigue syndrome because it's not my specialty, but I do see patients with chronic fatigue over the years. What have my patients taught me? Well, I take a careful history from my patients, from many of my patients with or without chronic fatigue. And one thing that struck me quite a bit. I found in most there was a past history of pretty rough stuff. Childhood abuse or trauma, other things, family dysfunction, severe, drinking and fighting among parents, bullying. A gay patient whom I asked, what was it like growing up gay in the rural area where he grew up? And he said his father rejected him, school was torture. Have you ever been depressed? No, very rough. So, for the most part, the patients I saw were not suffering from depression, did not complain of adverse effects, adverse emotional effects from a past history of abuse or trauma or severe stress. And again, that was consistent with what I had learned in some patients with hypertension about a history of pretty rough stuff and the absence of any emotional impact. And it led me to an understanding that I don't think exists in the chronic fatigue syndrome literature. In what proportion of chronic fatigue syndrome patients is this understanding relevant? I don't know. I think many, if not most. Is it discussed in the medical literature? No, it's not even considered in the medical literature. Are there studies that support this understanding and support my observations? And the answer is yes. Two things. One, studies show that the likelihood of a history of adverse childhood events in patients with chronic fatigue syndrome is much higher than in patients who don't have the disorder. It's not a coincidence. Could be double or triple the likelihood that they have a history of adverse events. Second, in almost every study of chronic fatigue syndrome where they measured sympathetic nervous system activity, the sympathetic nervous system activity was greater in patients with chronic fatigue than it was in those who did not have the disorder. Similarly, also, by the way, in patients with fibromyalgia. And again, what causes it? We know sympathetic nervous system is our fight or flight reflex. It's responsive to emotion. We don't have the conscious emotion here, but we have a story. And as I've described, emotions can live within us without our being aware of it. And it just has not come up as, gee, could that be a possibility here? And I think very strongly that it is, and we need to start thinking this way. And this brings us to the concept of repression and repressed emotions that I discussed with hypertension. Basically, with repression, it's at an unconscious level. We're not aware that we're blocking the emotions. We don't feel them. We would swear we don't have them within us. And that's repression. That's different than suppression, where, yes, but I try to avoid. I focus on other things and try to avoid those emotions. Here, no conscious effort. The emotions are not there. And I emphasize, and when I emphasize that repression is not psychopathology. It is a gift of evolution that protects us during periods of time when we would otherwise be emotionally overwhelmed. It's one of the greatest gifts of evolution. And but there can be a cost, years or decades later as those emotions persist within us, even though unfelt, affect our sympathetic nervous system and can affect us and possibly other mechanisms. It's a possibility, it's an understanding that neither physicians nor patients consider that emotions that people don't feel are affecting them. What about the role of an antidepressant? That's not clear. Studies are iffy. There is a catch-22, though, in terms of treating a patient with an antidepressant. Physicians are less likely to offer it in a patient who's not depressed. And patients who are not depressed are also less likely to volunteer for a study of antidepressants. So we have to be careful in interpreting the data, but the data simply is it's just not clear enough. I'm going to close with a story of my most memorable chronic fatigue patient and the lessons that it teaches. This is a patient who's a woman in her 60s, and she came to me because of suspicion that it was a low blood pressure that she had that was causing her fatigue. And her blood pressure, in fact, was on the low side. It was 95, 100, which is on the low side of normal. It did not drop when she stood up. And she also reported that during periods of time when her chronic fatigue was better, she had the same blood pressure, 95 to 100. So she was also very thin, and thin people have a lowish blood pressure. So I did not think, even though she was sent to me to evaluate the effect of her blood pressure, possible relation to the chronic fatigue, I did not think it was related. Her current life, ordinary stresses, nothing much. Given my experience with patients, I asked about past history, childhood history. She reported abuse, emotional abuse, physical abuse from both parents for years. During those years, she also had younger siblings, and she managed to be there for them. She was the only one that was there for them, and she was able to do that. She hadn't thought much about that past history. And we talked about it. And I explained to her how, despite the horrific conditions she grew up in, she was able to be there and be the hero for her younger siblings. And that was the result of the gift of repression that enabled her to do that. By this point, she was getting teary. She said, I've never shed a tear about those years, never. And she went home. Yes, she read my book. She cried. She got together with a younger sibling and they cried and cried. And her chronic fatigue syndrome lessened and was much better and stayed that way. We agreed it was worth seeing a trauma therapist. And at the third visit, the therapist said something to her I've never heard a psychologist tell a patient. She told the patient, you don't need me. She was doing well. And it was just a remarkable story. And it again illustrates how emotions that we are unaware of do affect us physically and can be related to any number of medical conditions whose origin we still don't completely understand, and particularly chronic fatigue syndrome, where we are so lost in understanding and treating it after all those years. We can do better. Again, I recommend my book, Hidden Within Us, which talks about the impact of emotions that we are unaware of repression. And again, I emphasize, if you look at popular books on emotional resilience, they don't mention repression. And again, I distinguish between repression and the suppression that we know we're doing when we're consciously avoiding emotions. So that's the story. I think this is an understanding that has received almost no attention in the literature or from doctors or from research psychologists. And please get the word out and please reflect. And I emphasize, repression is a gift. Not everyone is going to get in touch with those emotions, but if those emotions come up, trust the process. That barrier that protected you for so long, so many years, is not going to collapse from hearing a few words. Thank you.